Alaikum. Okay, I'm back with my second presentation. This is about IV thrombolysis therapy beyond hours in acute stroke. As we know that IV thrombolysis window, the purpose for thrombolysis or clot retrieval in the setting of ischemic stroke is to dissolve or remove the clot to preserve the ischemic penumbra and minimize the tissue size of the tissue infarct. The famous NINS trial published in 1996 that showed a 14% absolute increase in the best clinical outcome as measured by an NIH of a score of 0 to 1. It showed an improved outcome in patients who receive IVTPA as compared to patients as compared to control. The number needed to treat was 8 in order to get one additional patient with best outcome, while there is a 6% absolute increase in the risk of symptomatic ischemic intracerebral hemorrhage. The good stroke centers who deal with patients with acute stroke and thrombolysis, there are primary goals of thrombolysis. The primary goal, the good centers have organized protocols. They have designated a stroke team, but this team, the goal of the team is to achieve a door-to-needle time of 60 minutes in more than 50% of cases. And the secondary goal is that a door-to-needle time of 45 minutes in less than or more for 45 minutes or less in more than 50% of cases may be reasonable as well. If we compare how many patients who actually reach stroke centers in time and receive treatment, this is a comparison of two places where I have worked: University of Alberta, where I was trained, and Hamad Medical Corporation, where I've been working for the last 15 years. If you see that patients who percentage of patients who actually reach the center is 34% in HMC and 42% in University of Alberta. The patients who receive, this is 2019 data, the patients who actually receive IVTPA is in 2019 11.6% at HMC and 15% in University of Alberta. The patient number of acute stroke patients who undergo thrombectomy or underwent thrombectomy is 6% here and 10% in University of Alberta. And a combined treatment is about 15% here in Hamad Medical Corporation and 23% in University of Alberta. But so the reality is that because of the thrombolytic studies and system of care, the systems have gone major changes to make sure that TPA is offered to patients within 4.5 hours. This is supported by 2 trials, NINS and ICAS 3 trials. But does the efficacy of IV thrombolysis in acute ischemic stroke comes at a cost of increased risk of mortality and symptomatic hemorrhage? Why we are discussing this, because why the number of thrombolysis is still lower despite improved system care. This has been mentioned very clearly that the earlier you give TPA, the risk of bleeding is very small. The risk of symptomatic hemorrhage is very small. It's 1.3 as compared to if you move in the time window to more than 270 minutes, the numbers needed to harm increases significantly and overshadows the numbers needed to treat and benefit of TPA. The idea of giving intravenous thrombolysis is based on time last known well. TPA is efficacious in patients last seen well within 3 hours to 4.5 hours. Despite the proven efficacy of IV TPA, the majority of patients do not receive due to delays in arrival, inability to recognize event. And this has been shown very clearly in the different studies. As you can see, this is Get With the Guidelines registry. They looked into patients from population between 2002 to 2009, and it showed that more than 1/4 of the patient with ischemic stroke, they actually come within time window. time window. And this has not changed over the period of time. As you can see, from 2002 to 2009, the similar number of patients they reach within time window to be offered IV thrombolytic therapy. So last known well, although it is a conservative estimate of a stroke onset, there is about one third of patients who do not last known well criteria does not coincide with the actual stroke onset, and these are the wake up strokes. And now in the last few years, there has been a significant interest developed in trying to find a novel approach to safely expand the thrombolytic therapy for ischemic stroke in such group of patients. Up till now, for many years, we have different extended time period has been reviewed in different studies, starting from an Atlantis study to 3 to 5 hours till wake up and thaw studies up to 12 hours that investigators have tried to figure out the how to provide intravenous thrombolysis in a safe environment to improve outcome in patients in extended period of time. So overall, there is about 40% of acute ischemic stroke is caused by large vessel or proximal large vessel occlusion, and we know that proximal large vessel occlusions are associated with worse clinical outcomes. Most of these patients are untreated because of time-related factors, because patients do not come in 4.5 window, so we could not thrombolize them because of time constraints. Hence, now it has been we are looking into a transition time of therapeutic window that is tailored to each patient's individual pathophysiology or brain tissue window, rather than a standardized time window. Is a new paradigm where we are looking into the new studies are looking into how to extend that time window. We know that very well that there is a collateral collateral system of vessels which is evident only once the large vessel is occluded, and it has been estimated that if patients have poor collaterals, these poor collaterals are associated with a larger brain stroke volume as compared to patients who have good collaterals. As you can see here, patients have good collaterals, and it ends up at 24-hour smaller stroke volume. The different studies have shown that patients different studies have shown that in patients who are recanalizers, as compared to patients who are good collaterals who at the beginning, they recanalize their infarct volume is smaller as compared to patients with poor collaterals. Their infarct volume is even in the group of recanalizers, their infarct volume is much higher 24 hours as compared to patients who have good collaterals. And the infarct growth in even in patients with non-recanalizers but are good collaterals, their infarct growth is at a very smaller pace as compared to patients who are poor collaterals and recanalizers. Even their infarct growth is much faster as compared to patients with good collaterals. So along with that, patients who have intermediate or good collaterals and recanalize, their outcome at 90 days is much better as compared to patients with poor collaterals and recanalizers. Hence, we have understood with this evidence that collateral clock is in the time to come. Collateral clock is definitely more important than time clock for the fate of the ischemic tissue. This study done by Wiggle clearly showed that in patients who have poor collaterals, their infarct growth, as you can see, is much faster as compared to patients who have good collaterals. And the patient, and not only the infarct growth, but also the salvaging the penumbral tissue was lower in patients with poor collaterals as compared to patients with good collaterals. That the salvage of penumbral tissue is much faster. Similarly, in diffuse 2 trial, we have seen that even in patients who have poor collaterals, even if they come in early time, that their outcome is poor and they are called fast progressors towards infarction, as compared to patients who have good collaterals. They are even if they come late, they have a good outcome, and hence they are called slow progressors towards infarct volume. So at present, the current time window, as we all know, that for thrombolysis is should be given within 3 hours using the standard eligibility criteria, which is a level 1A evidence. And we also know that after the ICAS-3 trial, that thrombolysis can be extended to 4.5 hours in patients who are less than 80 years of age, or with the absence of diabetes and an IC score of less than 25 and not taking oral contraceptives, and who have less than one-third of MCO territory. So these patients can be given thrombolysis up to 4.5 hours, although different centers have extended the time window to 4.5 hours in every patient coming to the acute stroke with acute stroke diagnosis. So what about those patients who do not fulfill the time limit criteria? What should we do with these patients who come after 4.5 hours? There has been, as we know, that about 25 to 30% of patients who develop a stroke during their sleep. Now, there is a push that with the randomized controlled trials that to extend the IV-TPA window up to 9 hours in patients with acute ischemic stroke, with using newer modalities like MRI diffusion weighted studies in patients with unknown time of onset. The criteria used is called diffusion flare mismatch, which is a predictive of symptom onset within, so if this mismatch is present, the symptom onset is within 4.5 hours before imaging. So what is a diffusion flare mismatch? We know that diffusion shows acute ischemia within the first few minutes of an ischemic. So as soon as there is an acute ischemia, within minutes, diffusion will become positive. The flare changes can be delayed up to 4.5 to 6 hours. The mismatch is defined as if the mismatch is present, yani, if the diffusion scan shows hyperintense signal while the flare is still normal, it suggests that the onset is within 4.5 hours, a positive increased signal on diffusion and a negative not hyperintense flare signal. Diffusion says yes, there is an ischemic stroke, while flare says whether the ischemia has still not happened, or if the flare is positive, then it means the patient has already infarcted. There are multiple studies have been used over the period of time, which have used MR diffusion and perfusion, but recently 2 trials, which we are going to talk about, the Extend and the Wake Up trial, which showed significant promise in use of extension of thrombolytic window. Wake Up trial. The Wake Up trial is a multi-central. What they did is a randomized double-blind placebo-controlled clinical trial of adult patients with unknown time of onset, with signs of acute stroke onset were less than 4.5 hours based on the MR diffusion flare criteria to receive IV-TPA versus placebo. The outcome was standard outcome, which is MRS of 0 to 1 at 90 days, while there are some secondary outcomes based on shift analysis and proportion of patients receiving treatment and global outcome. Safety criteria was death or dependency at 90 days and symptomatic hemorrhage. The inclusion criteria was simple. All patients between 18 to 80 years of age and an ischemic lesion available on MRI diffusion scan, but no flare hyperintensity and measurable deficit. The exclusion criteria were all, the major exclusion criteria is that the patients who were for endovascular thrombectomy, they were excluded from this study. Otherwise, the rest of the exclusion criteria is the same. 503 patients were enrolled in the study, but the study was stopped due to lack of funding. They anticipated 800 patients. Out of this 503, 254 were received IV TPA, and 249 received were placebo. uh, the majority of patients were with unknown time of symptom onset was due to wake up stroke. 89% of patients. Median time of medication administration was 3.1 hours in from the onset as compared to, according to the imaging criteria, and 3.2 hours in the placebo arm. The study clearly shows, as you can see in the altiplase arm, improved outcome at 90 days in 53.3% as compared to 41.8% in the placebo group, which was statistically significant with an adjusted value odds ratio of 1.61. uh, both in favorable outcome and in the median MRS score. There is a significant trend towards increased death in which was not statistically significant, and intracerebral, and a trend towards intracerebral hemorrhage more in the thrombolytic group. The limitations of the study was stopped because of funding issues. Most patients with TPA had large vessel intracarotid artery occlusions, which typically undergoes endovascular therapy. These patients with large vessel, they go for endovascular therapy. So they were not the best patients to be in that arm. A small number of patients did not go for, because there's a smaller group of patients, so subgroup analysis was not possible. All investigators they were involved in image reading had to pass a software-based analysis training and certification before they were allowed to enroll patients. So so that's why the study is not possible at every center, which does not have MRI or neuroradiologists available at the institution. So that's why it can this limitation is this study is not applicable to on a routine practice in every center. The take-home message from this study is that in patients with acute stroke with unknown time of onset, IV TPA guided with a mismatch between diffusion and flare is in the region of ischemia resulted in a significant better functional outcome and numerically more intracranial hemorrhages than placebo at 90 days. In this multi-center randomized trial, patients with a stroke onset of unknown onset, the use of IV TPA was 11%. Resulted in 11% improvement in neurologic outcomes at 90 days, but although not statistically significant, they results in more hemorrhage and death. The second study was extent trial. What they did was this is a multi-center randomized trial, placebo-controlled, of acute ischemic stroke in patients presenting with 4.5 to 9 hours from onset, or those with wake-up strokes. These patients were randomized to take IV TPA or placebo between 4.5 and 9 hours. So all these patients who either wake up between 4.5 and 9 hours from last seen well, or from onset of a stroke, or awakening with a stroke, they were taken into from the midpoint of the sleep. They were taken into the study. The outcome was the same as any stroke study. MRS of 0 to 1 in 3 months, and secondary outcome of improved functional independence, early reperfusion, clinical improvement with NIH reduction, death, and symptomatic hemorrhage. Inclusion criteria is the same, except they used a penumbral mismatch and infarct code volume of less than 70 ml on MR diffusion weighted or cerebral blood flow. Exclusion criteria is the same as any other stroke studies. The results showed that patients, again, the study was stopped early because of because 225 patients of the planned 310 has been enrolled. Out of 225, 113 received TPA and 112 received placebo. The study clearly showed that patients who received TPA did a lot better than patients with placebo at 3 months. In terms of MRS 0 to 1 and MRS 0 to 2, they both showed statistically significant improvement in TPA arm. As you can see, patients with the TPA arm showed a significant improvement as compared to the placebo arm in terms of outcome at 90 days. So point to be noted from the study, extended study, is that it is terminated because there were thrombectomy trials reported, and study had to be stopped. And conclusion is that in patients with ischemic stroke with salvageable brain tissue between 4.5 to 9 hours from onset or from with these wake up strokes who receive IVTPA received better functional outcome, reperfusion, and early neurologic improvement. Mortality was comparable despite numerically more in the TPA group. The take-home message from the extended study is that this is the second study, randomized controlled trial with a stroke of unknown onset, that the use of TPA resulted in a 6% improvement in neurologic outcome in 90 days, but with more ICH and not statistically significant, but resulted in more death. Then following that, the meta-analysis is reported for all patient studies, four major studies, which use extended thrombolysis between 4.5 to 9 hours and wake up strokes using perfusion imaging. This meta-analysis included 414 patients, 51 patients receive IVTPA and 49% receive placebo. Out of this, 36% in the TPA group and achieved excellent functional outcome at 3 months. Symptomatic hemorrhage was more common in patients with TPA group, 5% versus 1%, while mortality was more in TPA group, but this was not statistically significant. So hence, there is a growing evidence that as we develop more understanding of collateral-based tissue injury status, IV thrombolysis with alteplase will become an option in selected group of patients, especially who are not amenable or waiting for thrombectomy. So what are other options? The other option is tenecteplase. There are multiple growing evidence now that tenecteplase is a comparable option in patients who receive who can be a candidate for thrombolytic therapy and not a candidate for alteplase. This is I'll show you a couple of slides on that. Randomized controlled trial of tenecteplase versus alteplase in acute ischemic stroke. This is a phase 2b trial. 75 patients were enrolled in 3 groups. First group containing alteplase 0.9 milligram per kilogram, second group receiving tenecteplase 0.1 milligram per kilogram, and third group containing receiving tenecteplase 0.25 milligram per kilogram within 6 hours from onset of ischemic stroke. Together, the two tenecteplase group showed greater reperfusion and clinical improvement at 24 hours as compared to the alteplase group. There was no significant difference between the groups in intracerebral hemorrhage or other serious adverse events. The higher dose of tenecteplase, that is 0.25 milligram per kilogram, was superior to the lower dose and to the alteplase for all efficacy outcomes, including absence of serious side effects at 90, absence of serious disability at 90 days, which is 72% versus 40% with alteplase. So the conclusion of this study was that tenecteplase was associated with significantly better perfusion and clinical outcomes than alteplase in patients with stroke who were selected on the basis of CT perfusion imaging after hours. Then there are, because there are a number of tenecteplase studies, there was a meta-analysis reported, which is comprised of 5 randomized trials, which contain about 1,585 patients, out of which 822 patients received tenecteplase and 757 patients received alteplase. The dose of tenecteplase used in these studies were 0.1 milligram per kilogram in 6.8%, 0.25 milligram per kilogram in 24.6%, and 0.4 milligram per kilogram in 68. So 1/3 of the patients receive 0.4 milligram per kilogram. The study showed very clearly that the meta-analysis showed very clearly that tenecteplase is non-inferior to alteplase in the treatment of acute ischemic stroke. These findings actually, so because of these findings, there was a support for the recent guidelines to consider tenecteplase to as an alternative to alteplase, as it is mentioned in the American Heart Association guidelines. You can say as a 2B evidence, and it may be reasonable to choose tenecteplase single bolus 0.25 milligram over IV alteplase in patients without contraindication of IV fibrinolysis who are eligible to undergo mechanical thrombectomy, and tenecteplase administered as 0.4 milligram per kilogram single IV bolus, although has not been proven to be superior or non-inferior to alteplase, but might be considered an alternative to alteplase in patients with minor neurologic improvement or no major intracranial lesions. So the conclusions of this presentation is that the time has come to understand that collateral clock for brain ischemia is more important than clock when it comes to matter of advanced treatment. Very soon, neuroimaging-based decisions regarding alteplase treatment in acute ischemic stroke is expected beyond the traditional time-based eligibility criteria. While the importance of time of stroke onset to treatment should not be understated, an increased role of neuroimaging in the individualized evaluation of ischemic stroke patient is promising for expanding the eligibility of thrombolysis. So neuroimaging is going to play a major role in coming times so that we can evaluate more and more patients for thrombolytic therapy. Expansion of TPA use to a broader stroke population may be at the expense of changing our current healthcare systems as well, because we need to have more ED community to be able to perform MR diffusion flare scans or some advanced CT scans so that we can evaluate more patients for extended time window. These studies do, however, further confirm moving away from a time is a brain paradigm to a perfusion-based strategy to see if there is a salvageable tissue instead of time cutoffs. This may or may not be beneficial to patients with a stroke with unknown onset of time symptoms, but TPA is certainly not a benign medication with trends towards increase on early mortality and increase symptomatic ICH. Hence, their studies need to be replicated to prove benefit and no increased harm in such patients. So the overall message is that in patients who come beyond present defined time window, we should use more imaging criteria to understand which patient can benefit from IV thrombolysis with alteplase or tenecteplase. But until that time, we have to wait for proven randomized controlled trials and approvals so that we can provide extended support to and care to our patients. Thank you so much.